Hi there, I'm Dr. Christopher Hammond, the new medical director for Los Alamos Fire Department. Most of you probably know me or have interacted with me at some point in time. I was the director probably 5 years ago for just a short period of time, and I've worked in Los Alamos for about the last 10 years or so. My background is emergency medicine trained, board certified. I did my training out in Baltimore and then moved back to New Mexico, where I worked at Christus and Espanola and some down in Cruces and Las Vegas. I mean, kind of been all over the state to some degree, but back here full-time in Los Alamos, where I'm the associate director of the department at the hospital and chief of staff this year for the hospital as well. So I took over this position in April, and our first initiative really was to roll out new protocols. And where those protocols came from was really the national standard protocols, and then tailored by Chief Bartlett and Manny and myself, really to kind of fit our local region and resources and needs. Those are definitely under construction, and we'll take feedback and criticism of those, or things that we need to change, or modifications you want to see, things that you want to start being able to do with our patients in transport. We want to hear some of those suggestions, and where we kind of go with that, we'll all talk about. But it's definitely a program and work that we want to be able to continue to modify, and not just have kind of stale protocols. So please always keep that in mind when you're seeing stuff and you want to start doing things. We're always open to suggestions. So a couple of things first before we talk about today's training. So because of COVID and our social distancing protocols and whatnot, we are going to be doing education this way to some degree, maybe in some smaller groups and some educational sessions, but it's a lot going to be online. I can't watch a video for an hour and try to learn something, and I certainly, with my ADHD, give a video for an hour because I can't sit that long and talk to people. So these should be fairly short, 30 minutes tops. I think today's maybe go 20 minutes. And what I'd like to do is we'll give this video the educational pieces that I would like to kind of get across to you guys as the crews. And then any questions, concerns, misspoken things that I've said or whatever, just email them to Manny, and he'll compile a list of your questions that then I'll address in the next month's educational piece as well. So any questions, let's just compile them. We'll address them in the next month as well. As your new director, I'm pretty accessible. So if you see my big Ford truck at the hospital, I'm there. You're welcome to come in and talk to me if you want to bounce a case off of me, something that didn't go right, concerns you have, questions you have, come in and chat with me anytime. I don't really use my Los Alamos County email, so don't send anything there, you'll never get a response. Best thing is really just to come by and see me when you're on shift, and I'm on shift as well. With that, my goal as your director is really, it's to monitor our the care that we're providing, but then also to make sure that we're really giving the best care that we can. So you're going to hear criticism from me, right? Just like I hear criticism from my director and our group, and things that I know that I need to change in my practice. So there will be things that come across the table where I think that you could have done a better job at something, or maybe not even better, just looking at it from a different perspective, or seeing it from my perspective on what happens when you deliver the patient to me. So if you hear criticism and you hear this, it's not a personal attack ever from me. This is about continuing to improve on what we do. So if you're feeling like I'm, browbeating you, that's not ever going to be the case. It's always going to be more of a, here's some educational pieces that you should take away from this, rather than something to just feel like you're being constantly criticized. But if you don't feel criticized at all, then you're probably not doing a lot. That's the other side. So if you're working, you're going to see more criticism, more constructive kind of pieces of advice to kind of carry from. So that's, I think that's how we all grow and how we learn. And that's probably all I have for that. So today's topic, we're going to talk about hyperkalemia. So where that came from is in our protocol for hyperglycemia, we have a piece that addresses patients who are hyperglycemic in DKA who may be also hyperkalemic. Kind of a rare setting, but we'll talk about some of those patients. But hyperkalemia in itself, we don't see a lot of, and especially in the field, you don't diagnose a lot of it. Plus, our patient population isn't that really kind of made up of those patients. A lot of where we see hyperkalemic patients are in our end-stage renal patients who are on dialysis. We don't have a lot of those up here in Los Alamos. Certainly in Espanola, we have a fair amount. There's a dialysis unit in Espanola, and same in Santa Fe. But we will come across some of these patients, so it's good to recognize this and then recognize it in our our diabetic patients who might be hyperkalemic as well. So with that, let me share my screen with you so you can see this handout, and you'll have this handout available to you. Just get this going. Okay, so we'll go through kind of the EKG changes, the treatment options, the potential, kind of risks of where these things go, and we'll just kind of march down this handout. I'm not a big fan of PowerPoint because it takes me forever to make something that you click on a slide and on the next one. So I like these little handouts, and then you can print them off or keep them, and whatever you'd like to do. So hyperkalemia, potassium, and we look at potassium. Most of the potassium in the body is not measurable, right? So when we draw blood, we're drawing serum potassium. Serum potassium is where the lower concentration of potassium is. Conversely to sodium, where sodium doesn't live mostly in the cells, it lives mostly in the serum, we get much higher numbers. So like a normal sodium level in the serum is 135, 140, and normal potassium in the serum is somewhere around 4, right? 4.5, I think 3.5 to 4.5 is what our lab uses. 5 is kind of upper limits of normal, and then 6 is where we start to say this is truly hyperkalemia. So most of the sodium in the body most of the potassium in the body is in the cells, mostly musculoskeletal cells is where you find it. And we'll talk about why that's important here in a little bit. Conversely, most of the sodium, right, in the body is not in the cell. So if you measured the cellular component of sodium, it would be within very low, like in the 4, conversely from the 4 of potassium in the serum to 4 of sodium in the cell, right? So they're kind of inversely proportional. We'll talk a little bit about why that makes sense when we talk about the physiology of the cell stuff. So clinically, when I was going through residency, what they always taught was in a hyperkalemic patient, first thing you do is you get an EKG, right? Not opposed to that, right? That's probably what we should do. But the old thinking was if there's no EKG changes, right? There's no peak T waves, there's no sine waves, there's no, prolonged QRS, then the patient's probably fine and they're able to manage their potassium level pretty well. So usually it means it's chronic, right? So it's these patients with hyperkalemia that live there chronically and probably they don't cause high, EKG changes. Turns out that's probably not true, right? So we have plenty of evidence in patients I've seen myself who are hyperkalemic with no EKG changes, who suddenly go from a normal sinus rhythm to VFib and code, or go into this wide QRS complex, and now it looks like they've got an acute left bundle branch block, and it makes no sense. Turns out it's probably hyperkalemia. So you can't go with the old notion of no EKG changes and the patient's fine. With that, so what used to be, so there are specific things that happen with hyperkalemia, and here's kind of the stepwise progression of what you see. So in hyperkalemia, the first thing you start to see is these peak T waves, and we'll look at some examples of this, then kind of progress into a widened QRS complex, where then you lose your P wave, and then as that kind of goes, you just get a sine wave, and then off into VFib. So the key point to me is EKGs are when they're positive, they're probably very sick. When they're negative, it doesn't always mean that they're fine. So here's an example, and I'm sorry it's a little fuzzy. I tried to blow it up, and it gets fuzzier as I make it larger. So 63-year-old woman, history of coronary artery disease, hypertension, end-stage renal disease, and is on dialysis. So here's your classic patient who's going to be hyperkalemic. They always present with this, right? Any dialysis patient always presents with weakness. She's got nausea, vomiting, and she missed her dialysis today. So dialysis is usually 3 times a week. So every couple of days they go, and and she missed hers today. I can't say that I've seen one up here in Los Alamos recently with that, but certainly in Espanola and Santa Fe, this is a common presentation of people who miss dialysis. So when you look at this EKG, first thing you obviously notice is just the peak T waves, right? Very sharp, demarcated peak T waves. Certainly in these precordial leads, you see it. You can see it over here, not as pronounced. QRS to the smaller peak T wave here, but very clearly evident that you've got peak T waves there. Some of what you can see with this or be mistaken with, and I'm not sure I could tell the difference without a history in a patient, right? If the patient's having chest pain and not a dialysis patient, I'm probably looking at this EKG thinking more these hyperacute T waves in the setting of like an early MI versus peak T waves in the setting of hyperkalemia. So history is probably important, very important, that goes along with being able to accurately diagnose this. So this patient, missed her dialysis, her potassium 7.3, and she's got peak T waves. And you also notice, there's no P wave in here. We look, lead 2 is often a great place to find P waves. There's no P waves preceding those QRS complexes. So we'll talk about the morphology of those things and then how to treat. So one of the acronyms people use for how to treat hyperkalemia is C big K drop. C being the calcium, and we'll talk about gluconate versus chloride. B is the beta agonist, and for us mostly that's going to be albuterol. ICU setting, sometimes that's epinephrine. And should we be giving bicarb to patients who are hyperkalemic? Of course, our insulin and glucose mixture, and then something you guys don't really give in the field because it's not a quick treatment option is K-Exalate and Lasix. And then eventually, basically, dialysis is the curative process for this. So let's look at peaked T waves in hyperkalemia. So in this one here, we've got, letter A, we've got a normal QRS complex, right? There's no widening of the QRS there. There's a normal P wave. The PR interval looks pretty acceptable, but that T wave is very sharp and peaked, right? So it's kind of, comparative to what you would see maybe with a left bundle branch block or even normal variants. They're a lot more broad in nature and not as kind of acute and peaked as what you see in hyperkalemia. So some differentiation between normal variants or some of the peak T waves in or hyperacute T waves in MIs and left bundle branch blocks and things like that. So that very sharp demarcated point to a T wave thinking about hyperkalemia for sure. Second thing you see in that progress, when they start to progress, is prolonged QRS as well as loss of P waves in hyperkalemia. So there's a nice peak T wave. This P wave looks pretty normal, right? Short PR interval here. And when we go to the next one, we start to see this PR interval that becomes much, much longer. So PR here is probably like 0.7 or so. I'm sorry, probably 4 on this one, maybe 0.5. You get out to this one, we start going over 0.8, 0.9 or so. Much longer PR, which then often progresses into just the loss of the P wave, and they go into a bradycardic, different nodal rhythm than our sinus nodal rhythm. The other big finding is the widening of the QRS. So these are kind of fun because you see this on just your normal monitor. And so if you've got a patient who's hyperkalemic, when you start treating them, you very often will see their QRS interval just shorten. Give a bunch of calcium and you watch that QRS just really kind of narrow. Pretty fascinating to see EKG changes that fast. Hard to differentiate when we start talking about left and right bundle branch blocks. We're not going to get into that detail today, but that's another topic for discussion. But left bundles and right bundles are going to have wide QRSs. Their T waves are going to look a little abnormal, and so it can be tricky. So again, the clinical setting is really where you're able to identify this a little better. The next progression is the sine wave, right? It's pretty hard not to miss this when you see a pattern like that, and then obviously VFib. So the way I think about it is hyperkalemia often just stretches the entire EKG out, right? So as you begin to stretch, you get a little peak T wave, then you lose the P wave, then the QRS widens, and then they go into a sine wave, and then they go into VFib. So it's almost like the stretching of the QRS. And then the next is asystole, right? Fully stretched out. So here's a pretty good EKG. I love computer reads because they actually, when they're normal, it's probably okay. When you have an abnormal EKG, computer reads are the worst thing possible for you. So this one's read as an acute MI with a ventricular rate of 100. So look at that, and there's certainly not a ventricular rate of 100. So it's picking up whatever other electrical activity in there and counting that on a regular beat. But this is probably somewhere, if you start at this one, 300, 150, 175, 40-ish, so a rate of somewhere around 40. So it's going to be either a ventricular rhythm because there's some massive block, or it's going to be hyperkalemia. What you find is any EKG that you really can't identify what in the world it is, it's probably hyperkalemia. It shows the weirdest, absolute weirdest stuff on EKG across the board. I've been fooled multiple times by hyperkalemia when I'm looking at an EKG. So in this one, you can see, let's look here at a rhythm strip in lead 2. Maybe that's a P wave. If it is, that PR interval is really long. I don't see one there. Maybe something there. But QRS is enormously wide, wider than you would even want to measure. And some weird looking morphology to the T. I don't even know if that's the T wave there. I mean, something, right? So it's just really bizarre EKGs. Hyperkalemia is where your mindset should go. Here's another one, right? Pretty obvious, very peaked T waves, especially in those precordial leads. I don't see, you can always make stuff up, right? So in here, I don't see a P wave. In lead 2, when you're looking, maybe this is the QRS and a P wave and then a T wave. Extremely abnormal. Your diagnostic criteria here is this very sharply demarcated T wave, which left bundle branches look somewhat like this, right? You get this big, deep, QRS complex that goes into a large T wave, but usually so much broader in the QRS and so much broader of a formation in the T wave as well of a left bundle branch block. Did they even call this one? This patient had a potassium of 9, right? So this probably an end-stage renal patient who could handle high potassium levels, because a potassium of 9, you're probably dead pretty fast. Another example, again, really bizarre. It doesn't really fit the morphology of a left bundle branch block or even a right bundle branch block, because your QRS is just really wide. Some weird T wave or P wave in here. Maybe there's some combination of a P wave there, but a PR interval that's enormous, right? So these are pretty classic hyperkalemia, which you don't see most of the time in the field, right? And so this is something you get eventually in a hospital as you're monitoring people. In the field, even in the ER, you just get these ugly looking EKGs that you can't explain, and that's where your mind ought to go to hyperkalemia. And last one here. So this is almost getting to the sine wave pattern, right? So you see this kind of nice rhythmic, flow to this, and there's nothing in there. No P waves, no T waves, huge QRS complex. I mean, there's just nothing there. So if you see that one, that freaks you out, right? Somebody's about to die. So where does hyperkalemia come from? We talked about our end-stage renal patients for sure, right? Because they can't process it through their kidneys and then excrete it in their urine. So it just builds up, and then they get on dialysis and they pull it off. So a couple other causes. Excessive exogenous potassium, probably not common, right? You're not going to eat enough potassium to cause hyperkalemia, unless there's something wrong with your kidneys, again, that you can't process this and then excrete it. More commonly, it's excessive endogenous potassium, right? So it's your body's breakdown of something, of cells, of red blood cells, of muscle tissue, of a tumor breakdown, something that's destroying tissue in your body that then causes your potassium to go up. So crush injuries, patients pinned under something for a couple of days, and then they get pulled out, have a sudden surge of potassium in their serum. Massive trauma patients, your burn patients. So think about tissue destruction is probably going to be the next place that you see elevated potassium levels, and then the effects of that on whether it's cardiac, and we need to treat, or it's something along those lines. Where the other place I definitely see it is in your hyperglycemic DKA patients. You can see who are acidotic, and you'll see their potassium high. That ends up being beneficial to them as long as it's not too high. And we'll talk a little bit about that. Certainly, there are medications that do it, and so succinylcholine here is a common one because they fasciculate, so you end up releasing potassium. So I had a pretty nasty pinned patient who got pinned under a rock for 6 hours, and when we pulled them out, kind of the first thought is, if they need to be intubated, what do you use? And succinylcholine is going to add to that potassium level because of the fasciculations. And so we end up using rock uronium commonly in these trauma, burn, crush injury type patients instead of succinylcholine when we RSI them. The common one, other etiology, excretion problems. So you renal failure, some of the glucocorticoids kind of inhibit some of the excretion pathways. And so you can see it there as well. Of course, there's got to be medications that cause this. There are medications that are potassium sparing, like spironolactone for high blood pressure. That's potassium sparing. Overdoing it on that, dehydrating a patient, you can often see this, show up in a patient who has normal renal function, but too many doctors, too many hands making changes in medications is where I've seen this as well. And then there's just the falsely elevated hyperkalemic patients. Most commonly, it's going to be, basically you just hemolyze the blood in the tube and you got to recheck it. So let's go into treatment options. C big K drop is the kind of one of the acronyms people use. We won't get into the physiology of like the molecular biology of cells, what do the cells actually do? We can address a little bit of that and what happens, but I spent in undergrad a long time studying some of these pathways, and they're just tedious, but it's nice to know what is actually happening and where it is and why you give a certain drug. So first thing that I always do, hyperkalemic patients or these weird EKGs, there's nothing wrong with giving calcium. So calcium we talk about as it's the stabilizer of cardiac basically depolarization. So as potassium kind of rises in the cell to a certain threshold, then you get cardiac contractility, and that becomes destabilized when potassium is out of whack because of this sodium, potassium, calcium ATPase pump. So if you look at schematics of this, it's really how does potassium move into the cell, sodium move out of the cell, and then it's stabilized by a calcium ion as well. And so first drug always to give, if they're hyperkalemic, hyperkalemic, and they're a dialysis patient, they've got a weird EKG, this is certainly your very first thing to give. In your DKA patients who are just cruise-mole respirations, weird EKGs, there's nothing wrong with giving calcium in that setting. So once you decide to give calcium, the question becomes, what calcium do you give? So there's two forms, calcium gluconate and calcium chloride. So two different reasons to give, kind of the varying drugs. So calcium gluconate is basically 1/3 the strength of calcium chloride. Calcium chloride there being 3 times more potent than calcium gluconate. The benefits to calcium gluconate is you can give it through a peripheral IV. Calcium chloride really should be given through a central line, a port, a PICC line, something that is not a much larger vessel so that it's not so venotoxic, right? So you can degrade a vein, you can cause tissue necrosis if you give it through a little 22 in the hand or something, and then it extravasates, and then you've got necrotic tissue. So safest bet for us in the field of what we use in Los Alamos will be calcium gluconate. So that's what the protocol has written, and we'll look at the protocol here at the end as well. So calcium gluconate, 1/3 the strength of calcium chloride. So you've got to give 3 grams of calcium gluconate to give basically 1 gram of calcium chloride. Part of its downside, it has this huge glucose molecule attached to it, hence the name gluconate. And so you really should be given this over 5-10 minutes. It's probably 5 minutes in the setting of a patient who's got EKG changes and weak and vomiting. We probably should push this over 5 minutes or so. 10 is probably a little too much, so our protocol says 5. Part of the problem with calcium gluconate, because it is a sugar-based molecule, is do you need adequate liver function to be able to break this down and be able to use it? We think that's probably kind of an old thought process, and that even giving calcium gluconate to an end-stage liver patient, they're still able to break down the glucose and the calcium out of that and use it. But one of the old thought processes is that because of that, patients with liver disease weren't able to do that. I think the jury is probably still out to some degree, but it looks like mostly they're able to use it. So even in your liver patients, critically ill, liver failure, you can still use calcium gluconate safely peripherally to stabilize their cardiac membrane. Calcium chloride. So this is really what I use it probably in the hospital more than calcium gluconate, because when I'm giving it, it's the sicker patient, it's the coding patient, it's the I've got to put a central line in and now I can use this, something like that. But I think for you guys in the field, certainly the calcium gluconate is the safer choice to use and the most appropriate. So calcium chloride, for what I probably use in the ER, 3 times more potent than calcium gluconate. So I only need to give 1 gram of this versus 3 grams of gluconate. They can push it much faster because it's a chloride. It's two ions, not large molecules. It's just 2 ions of calcium and chloride. So I can push it much faster. What the downside is it is venotoxic. So I always give this through a central line or a PICC line or something like that. There is no sugar molecule, so you don't need a liver. And here's the downside, right? If you screw up and it extravasates into their tissue, they often get necrosis there. So I use this because people are sicker, right? When sicker with me and I've got their potassium level back, or I know their EKG changes, I can reverse it much faster by giving them calcium chloride rather than calcium gluconate. Pertinent to know about both of these, especially if you guys are doing transfers on some of these patients, is if I've fixed them in the ER and I've given them calcium and insulin and glucose and I say everything's fine, and by the time you get down the hill to Powake and their QRS complex starts to widen again, you should repeat all the stuff I just did, because most of the stuff only lasts 30 to 60 minutes or so. So in that algorithm of how you treat this, calcium is always first, right? I'm going to start with that, and then I'm going to give the rest of the thing that are going to kind of shift potassium or excrete potassium. But the first thing is to stabilize. So we call it stabilization, kind of shift of potassium, and then excretion of potassium is how it goes. So that was stabilization in part of, kind of transferring potassium from the serum and putting it back into the cells. There's a couple ways to do that. One of the ways in that, this little acronym C big K drop. So the B is beta agonist and sodium bicarb. So beta agonist, none of us probably ever do this unless, again, really sick patients is probably where you get to this, but it's the idea behind what you can start. So beta agonists are catecholamine, so it's like running from a bear, right? So I give a bunch of albuterol to somebody who's an asthma attack, opens their lungs up because it's a stimulant, right? It's a catecholamine or an adrenergic agent like epinephrine, and it's going to make things fight or flight kind of stimulation. And what that does is it basically just stimulates the sodium potassium ATPase pump or the sodium potassium chloride pump, and there's thousands of these things. But it stimulates these pumps to start to shift potassium. And you shift potassium, usually 2 ions of potassium for 3 ions of sodium, because there's more sodium in the cell, and we shift some of that back into the serum. There's more potassium in the cell, and we can take some of the sodium, put it back in the serum, and then exchange it for the potassium that's in the serum as well. And so it's just this cyclical nature if you can stimulate the pump. So catecholamines like albuterol do that, but they don't do it like we typically treat COPD or asthma, and we give them 5 milligrams of albuterol and a duo neb or something like that. They need significant amounts of catecholamine. So the real treatment for hyperkalemia in treating with a beta agonist like albuterol is something around 20 milligrams is what we want to use. So when we look at our protocol says 5 milligrams. It's something that we discussed, but just not ready to jump to yet, right? Are you going to mix 20 milligrams of this in a patient who's sick as can be and 89 years old? Is that something that you should be doing in the back of an ambulance, or is it something that we should be doing in the emergency room? But we landed on currently just using 5 milligrams Usually by the time you get that in, you're at the hospital anyway. So to give a 20 milligram neb probably takes 30 minutes to an hour. I mean, it's a substantial amount of time to inhale that much. Epinephrine is another beta agonist, catecholamine stimulator. I'll be honest, I don't use this in really the acute setting at all. The only time that we've used this is really in these recurrent hyperkalemic patients who are waiting for dialysis because they basically need a new port or something, that their dialysis is delayed. Then we'll use epi drips to kind of shift some of this. Not a common use that I do at all. Bicarb is one of those kind of controversies in the setting of hyperkalemia. So bicarb is basically what they did is they looked at studies in an ICU where they had really sick patients who were acidotic, and they were giving them bicarb, and they saw a change in their, decrease in their potassium level. That never really panned out in the acute setting as a problem. So to give an amp of bicarb or 2 amps of bicarb to make them a little more alkalotic or stabilize their acidemia, it never really worked. But what was working and where it was derived from was in the ICU. If you put these guys on a bicarb infusion over hours and hours, 6, 7, 8 hours, you start to see some change in their potassium level. So it's truly, there is a time and a place for it, and probably the only time that I really use it is in my really acidotic patients. So my DKA patient who's also hyperkalemic, who has a potassium of 7 and has a pH of 6.9, that's probably the patient who's appropriate to get that. Yeah. So mostly, potassium of less than 7 is probably where I start to give it. So next step, right? So we treated with calcium first, stabilize the patient, get their heart from doing crazy stuff, narrowed their QRS complex. As we're pulling up those meds, you can throw them on some albuterol. Our protocol is 5 milligrams. They need a hell of a lot more than that. You can give some bicarb in the acidotic patient if appropriate. And so we're still in the shifting of potassium phase here. We're not even on to getting it out of the system yet. And the next treatment really is insulin glucose. That's a very common thing that we all give for hyperkalemic patients. Again, not part of the normal protocol that we're looking at today, but this is where it'll head. Insulin, again, its physiology here is it stimulates the sodium potassium ATPase pump, and it causes a shift again of potassium out of the serum and back into the cell. But we haven't gotten rid of anything yet. This is, again, a temporizing measure that you'll see some change in potassium, but it's not permanent. So how do you do it? 10 units of insulin IV with a couple amps of dextrose. I'd much rather have a hyperglycemic patient than to make somebody hypoglycemic after I give them some insulin. So I usually give 2 amps of dextrose, unless they're the DKA patient with a sugar of 800 or something like that. I always give it IV. So the reasons you give IV insulin is when you want rapid, short-acting effect, or a long-term infusion like in a DKA patient. And I give sub-Q insulin when I want a much longer, slower-acting effect, which is your hyperglycemic patient who's not acidotic, who's not in DKA, and you're just treating sugar levels. That's where you use sub-Q insulin. Sick patients, we use IV insulin. This one of the things I find with insulin is this is such a small amount, 10 units to be given and drawn up. Half the time you put it in a tiny syringe and you push it and it's still in the cap when you do it. So I always tell nurses, take the insulin, put it in a flush, and give the whole flush so we know that the full amount is in and pieces aren't sitting in the cap or the tube. So if we do stabilization, cellular shift of potassium, then it's a matter of getting potassium out of their system. So 2 easy ways that we do it, and most commonly in our hospital, this is how we do it. If it's a normal, semi-normal renal function patient who is making urine and is not anuric, you give them 40 milligrams of Lasix, and in the tubular structure of a loop diuretic in the kidney, you'll excrete potassium that way. So you can lose somewhere between 0.4 and 0.7 milliequivalents of potassium over a certain amount of time. I don't do those calculations. but Lasix for sure. So 40 milligrams of Lasix is what we'll give. And then with that K-Exolate, which is an oral liquid that you swallow that helps bind potassium in the GI tract and then excretes it when you have a bowel movement. So when you're constipated patients that can't have a bowel movement, or if the patient has a bowel obstruction and is hyperkalemic, this is not an effective treatment because you have to excrete the K-Exolate, which binds the potassium, in order to lose the potassium. There's a couple other meds out there that you might see. One of them is a polymer bead of some type that will bind potassium and then you excrete it. K-Exolate's gotten a lot of flack, but you'll find every internist on the planet uses K-Exolate, but you'll hear some bad stuff about it if you look it up at all. And then the final way to get rid of potassium is dialysis. So this is the primary reason we transfer these patients, because they need dialysis, and that's really just their definitive care. And so when you see a couple of these patients we've transferred out of here the last couple of years, it's because really they just need dialysis now, and it's curative, right? So you do dialysis, 4 hours later, your potassium will be normal, and they'll make sure it's normal. So really, just in summary, a couple of key things. So potassium, predominantly is found within the cells, not in the serum. And hyperkalemia really becomes a problem when we start to affect cardiac tissue, which is why we give a cardiac membrane stabilizer first of calcium to stabilize this. EKGs are not your end all be all, right? A normal EKG in a hyperkalemic or suspected hyperkalemic patient doesn't mean to let your guard down, or doesn't mean there's nothing wrong. It really, a normal one is probably just as concerning as an abnormal one that you're treating. Here's your management. We start with cardiac membrane stabilization with calcium, transcellular shift with, for us, it's going to be albuterol, maybe bicarb in an acidotic patient, and insulin and glucose, and then excretion, which is going to be through first Lasix, which we can give if they're making urine, second through K-Exolate, which through the GI tract, and then finally dialysis. Calcium gluconate is your membrane stabilizer. What you're going to use in the field most of the time, and what I'm going to use is calcium chloride in the hospital, and certainly in my obvious cardiac arrest patients and critically ill are going to use calcium, not gluconate, chloride, in these sicker patients. And you guys in the field, even if they're sick, like calcium gluconate's what's in our protocols to give for now, but just understanding why we're doing it that way, because of the tissue necrosis, the central venous access that you need that we're not getting in the field, things like that. All this stuff is short-lived, beta agonists, insulin, glucose, and it just causes a shift. And so again, in these transport patients, if you're taking them down to St. V's for dialysis and you see changes again, we're going to need to repeat what we just did in the ER, because 30 to 60 minutes is really the time frame that it lasts. Bicarb, not a common one unless they're the acidotic patients. Here's your excretion, whether it's through urine, K-Exolate in GI tract, or dialysis. But truly, dialysis is where you want to get most of these patients, unless there's a reason why they're acutely hyperkalemic. And let me just change this. Okay, so, oh man, I messed up. Here's one more. Let me share my screen with you again. I want to pull up our protocol. So lastly, this is where kind of this question came from of what do we do, why are we giving in hyperglycemia? Why are we treating it like they're hyperkalemic? So you have calcium gluconate in an adult, 2 grams over 5 minutes. Pediatrics are usually going to be about the same. It's 100 milligrams per kilogram. A 10-kilogram baby is going to get a gram. A 45-pounder, 20-kilogram kid is going to get 2 grams. So most of the time it's going to be 2 grams over 5 minutes or so. Here's your bicarb, 1 milliequivalent per kilogram. It's in most people, again, it's an amp. and then your albuterol. And that's really where this came from, was why is this even on here? We started again with the 5 milligrams just because our short transport times are, we're kind of low volume of end-stage renal disease patients. But it's just something to consider. So when you pick up your DKA patient who's small respirations, who looks like they're acidotic, and they've got EKG changes with peak T waves and no P wave, it's there for you as an option, right? First and always go to in that setting is always calcium, because it's the thing that's going to keep them alive. Then you can add some shift with a bicarb or starting some albuterol, which by the time you even get up the hill from White Rock, you've probably got one of these in, and we'll add 3 more by the time you get there. So that's where all this came from. And again, this is under the hyperglycemia protocol at the very bottom for your treatments. Okay, so that's all I have. That's kind of it in a nutshell. If you have questions, please email them to Manny, and we'll talk about them in our next month's briefing, and go over whatever questions, concerns, or thoughts that you have on that. And if you have topics that you want to address, that we want to do a 30-minute video on and talk about, email those to Manny as well, and we'll start addressing those just on a month-to-month basis, whether it's video conferencing or whether it's in person when we're allowed to do that. So thank you guys for your time, and appreciate you watching this, and we'll see you soon.